Do you benchmark on a national database with your sepsis information, or is it purely an internal system?
I have internal, but I have had national databases since 2004. I had the Project Impact database, and now I look to the big IHI article that was published. Have you downloaded that journal article just published?
No, not the recent one.
Okay, if you can look it up, get your librarian on it, and she'll find that. It's the Surviving Sepsis Campaign Quality Indicator results with 15,100 patients, I believe, in that database, and they do have some big studies. You can also go, if you're part of the IHI, are you part of the IHI?
Yes.
Okay, so that has some data as well, although I don't think a lot of that data is truly accurate.
Yeah.
If you're only pulling from ICD-9 codes, the data is inaccurate because you get the intracerebral hemorrhage that was in ICU for 3 weeks, gets one bacterial infection, and now they look, those kind of muddy the waters to me. That makes your data look very, very different. So what I do is I actually look at the patients who, when I specifically look at my quality indicators surrounding sepsis in terms of assessing the efficacy of your initiative at your hospital, I look at the ones that were truly on the sepsis protocol, admitted with sepsis, or developed sepsis on the floors, that they were treated with the 6 and the 24-hour bundles. And then you can look at all those other patients in a different way. But if you're looking at length of stay, percent intubated, mortality on the other group, like we're a trauma center and we have a very, very aggressive neuro ICU here. We do a lot of hypothermia, ICP and LICOX, CRT, proning. And so if I looked at those cases, I like to look at them differently than the actual severe sepsis septic shock patients admitted to my hospital with a true infection. So in terms of assessing the efficacy, I like to look at them differently. That article will help you.
And then did you share your information at the beginning on if we had any further questions that I could be able to contact you?
Oh, of course. We have to share. We have to communicate. We have to work together because our patients deserve it. We all need to help each other. And, of course, certainly I will talk to anybody on the phone. And I'm not saying that what I do is perfect. I have a long way to go. As a matter of fact, I'm doing a rapid improvement event in a few weeks where I put Post-it notes on the wall and look at our entire process and where are those decision points, where are those triggers, and how can we do it better. I have ED nurses, floor nurses, critical care nurses, and my intensivists all in the same room and say, where are we missing our opportunities and how can we do it better? Because I think a lot of us, we put in these initiatives kind of knowing they're not the perfect initiatives, but we have to do it that way to make all of our key players happy. But then at that point we can iterate, make it better, make it different, improve little by little as we move forward. And I think adding PCT is one of those iterations that really have a significant impact because it's helping us to see our patients for what they are.
Here's a question that I think is getting at the value of serial testing. The question, if your lactate is elevated and you are already doing your sepsis bundle, how would doing PCT give any additional benefit?
Because it goes down if the efficacy of your therapeutic modalities are correct. In other words, what are empiric antibiotics? They're best guess, right? If you're not guiding your empiric antibiotics from location and community versus hospital acquired, how do you know if your empirics are working? And I think that I have seen at my facility, and I'm not talking about other people, just myself, I've seen that PCT go from 100 to 5. And I know that my best guess antibiotics, until my culture comes out, and the results of the blood cultures and sputum cultures, and I know what antibiotic I'm going to transition to, which we do. We like to decelerate our antibiotics as soon as possible so that those big gun antibiotics are not utilized for days on end if it's not required. So I think it looks to the efficacy of your initial therapeutic plan. That's why I think it's good. And also, if it doesn't budge, maybe you're looking at it wrong. I had a young guy come in that he was only 16, and he said that he had a urinary tract infection when it turns out he had an epididymitis. But he didn't want to show the nurses that his scrotum was the size of a grapefruit because he was embarrassed. So he said he had a bladder infection. So he went to the floors and ended up getting worse, went into ARDS, was intubated for 4 days, and of course the minute he went to ICU, the nurses then noticed that he had a very large scrotum. They switched his antibiotics because for him, we had him on urinary tract empirics, not skin and soft tissues empirics. So we had the wrong antibiotics. That was before we were doing PCT. Had we done serial PCTs, we would have noticed that that PCT probably wasn't budging.
Here's a question. What about the usage of STO2 tissue oxygenation and its role in managing fluids in the 6-hour bundle?
I would be so excited if we had STO2. That's looking at the phenar. It's another way of doing SCVO2 monitoring. It's the tissue oxygenation. Believe me, I've been playing with that machine for years. I think the issues with that company, it's still a bit on the expensive side, so for us it's cost prohibitive, but absolutely looking at endpoints to guide your fluid resuscitation will ensure that you're not giving any additional fluids. We know that fluid resus has a cost, don't we? And we know that over-resuscitation is not a good thing. I do think that 90% of our patients are under-resus, but we certainly don't want to over-resus either. So utilizing that STO2, I think, would be great. We did test it out here. We didn't have the best experience, but I know many, many facilities nationally that are using it that have had excellent response to guiding their fluid resus. So, yeah, let me know. Again, let me clarify my contact information. It's Kirsten, Kirsten, Springer, Springer, at stjoe.org, stjoe.org is my contact information. And please let me know your experience because I'm always looking for ways to make my program more successful. I know we can do better.
Well, with that, I'd like to thank everybody for their participation today. It's really been our pleasure to bring this great group of people together and the discussion that we've had. And thank you again, Mrs. Springer, for an outstanding presentation. There is another webinar that's going to be offered by bioMeriU in a couple of weeks on Wednesday, July 14th. That webinar will focus on PCT and the ICU and the emergency department. And again, we'll send a reminder email about that webinar. So with that, I want to thank everyone for their participation today, and I hope you have a wonderful